بسم الله الرحمن الرحيم. I think this is the first lecture about diabetes mellitus, about classification, pathogenesis, and diagnosis of diabetes mellitus. What are the intended learning outcomes concerning this lecture? Number one, to define hyperglycemia in clinical practice and discuss clinical approach of hyperglycemia, classification of diabetes, simple classification of diabetes, and identify common categories. What are these categories? Type 1, type 2, secondary diabetes, and gestational diabetes. Also, to discuss the state of impaired glucose tolerance and its clinical importance, describe pathogenesis, diagnosis of different types of diabetes, and how to assess the patient clinically. The commonest type of diabetes, type 1 and type 2, how to differentiate between them, and it's a very important point. What are the agenda of this lecture? Number one, definition, classification, pathogenesis, diagnosis, and the case scenario. Diabetes is not a single disease, and it is not an acute disease. It is a group of chronic heterogeneous metabolic disorders. Type 1, type 2, gestational diabetes, secondary diabetes. But the hallmark of all these metabolic disorders is hyperglycemia. What do you mean by hyperglycemia? Now, at time being, only just elevated blood glucose level. The disturbance not only in the carbohydrate metabolism, but also in fat and protein metabolism. It results from defects of insulin action or insulin secretion or both. As part of the clinical definition of this group of disorders, often accompanied by specific microvascular complications like retinopathy, nephropathy, and peripheral neuropathy. Also, non-specific macrovascular complications like coronary artery disease, cerebrovascular disease, and peripheral vasculopathy. What is the epidemiology of diabetes? Diabetes is a major public health problem worldwide, not only in Egypt but all over the world. This public health problem is a costly problem. It is not just increased number of cases of persons affected, and now we are in the epidemic of diabetes mellitus. WHO reported that the number of cases will be doubled every 25 years. And Egypt, one of the 10 top countries all over the world, contain number of diabetics. It is not just increased number of cases, but also associated morbidity and mortality. All of us know that the commonest cause of end-renal failure is diabetes related. The commonest cause of blindness all over the world is diabetes related. And the commonest cause of non-thrombotic balloon amputation is diabetes related. Also, the mortality rate is very, very, very high in diabetic patients. Prevalence rate in diabetes as time being around 9.5% the age group above the age of 20 years, but the incidence, which means that new cases per year of type 1 diabetes is very low, and for type 2 is very high. And it is very difficult to estimate in Egypt because the diversity of the healthcare services in Egypt. Still, the ratio between type 1 and type 2 is 1 to 9, and females are commonly affected by type 2 diabetes mellitus. The simple classification should know diabetes mellitus are classified into primary diabetes and secondary diabetes. Primary diabetes, type 1, like autoimmune and idiopathic. Type 2, predominantly insulin resistance, around 80% of cases all are obese, and predominantly insulin secretory defect, around 20% all are non-obese. Secondary diabetes, secondary pancreatic disease like pancreatitis, pancreatectomy, neoplasia, and hemochromatosis. And endocrinopathies, acromegalyx, 25% of acromegalyx are associated with diabetes. Cushing syndrome, pheochromocytoma, and hyperthyroidism. Also, drug-induced, in particular, the long use of corticosteroids. The third category of this metabolic disorder is gestational diabetes mellitus, which is a peculiar type of diabetes. We'll discuss later on. It is just a type of diabetes that first recognition during pregnancy may or may not disappear after delivery. Since the hallmark of diabetes mellitus is hyperglycemia, our approach is related to hyperglycemia. There are 5 questions. around hyperglycemia. And question number one, what is hyperglycemia? What are the clinical types of hyperglycemia? What are the causes of hyperglycemia? What are the symptoms of hyperglycemia, and how do clinical approach of hyperglycemia? In a simple term, hyperglycemia means elevated blood glucose levels above the normal values, or it is a condition in which there is an excessive amount of glucose that circulates in the blood. There is no figure now, but later on we will see that hyperglycemia means that elevated blood glucose level above a certain figure, just to discuss later on. Hyperglycemia may be symptomatic or may be asymptomatic. Yes, symptomatic hyperglycemia, when the blood glucose level increases in the blood, it reaches above the renal threshold of the individual, which is in the average around 180 per milligram per deciliter. Once it elevates above this renal threshold, it passes the urine, causes symptoms like increased urination, what we call polyuria, and increased thirst, what we call polydipsia. And the commonest cause of this type is diabetes, type 1 diabetes, also maybe type 2 diabetes mellitus, presented by this symptomatic hyperglycemia. So causes of symptomatic hyperglycemia: diabetes, primary or secondary diabetes. Primary, two presentation, maybe acute, classic, and severe presentation like type 1 diabetes mellitus. But this symptom may be a classic or subacute presentation, takes long time, like type 2 diabetes mellitus. Secondary diabetes commonly associated with symptoms like endocrinopathies, pancreatic disease, and drug-induced like corticosteroids. Clinical presentation of symptomatic hypoglycemia. There are four. Number one, the first presentation, acute and classic and severe presentation. Number one, polyuria, once the blood glucose elevated above the renal threshold with passing the urine, but osmotic diuresis causes polyuria. What do you mean by polyuria? Polyuria means increased urine output more than 2.5 liters per day, and it is due to osmotic diuresis. If we say that increased urine output more than 2.5 liters per day, usually associated with increased frequency, increased number, as well as increased amount, and may also during the daytime and during the night, what we call nocturia. Polydipsia due to cellular dehydration, and polyphagia due to cellular starvation and weight loss, which is multifactorial, like due to loss of fluid and increased catabolic process. The second presentation may be subacute, or that occurs in older persons for takes several months, like thirst, weight loss, and polyuria, lack of energy, blurring of vision, or sopranitis or pruritus valve. There are signs of symptomatic hyperglycemia in acute, classic, and severe type 1 diabetes. No clinical signs related, but in fulminant cases may be signs of severe dehydration and acidosis, like what we call diabetic ketoacidosis. One of the acute emergencies in diabetic patients, particularly in type 1, maybe around 1/3 of cases may be presented for the first time by this acute metabolic decompensation. Asymptomatic hyperglycemia, a large number of individuals currently diagnosed have diabetes mellitus, in particular type 2 or impaired glucose tolerance and gestational diabetes mellitus. All are asymptomatic, there are no symptoms. So what are the causes of asymptomatic hyperglycemia? Number one, primary diabetes, only type 2 diabetes mellitus. Maybe accidental discovered like glycosuria, routine blood glucose, routine blood glucose measurement, may be presented by chronic complications. And this is a dangerous situation. Around 10 to 20% of cases may be presented by chronic complication for the first time. So there is no symptom. Like, for example, mother get a large baby, macrosomic baby, unexplained peripheral neuropathy, premature atherosclerosis, impotence, and so on. The second cause for this asymptomatic hyperglycemia is impaired glucose tolerance, and third one is gestational diabetes mellitus. All these are associated with no symptoms. What are the signs of asymptomatic hyperglycemia? In type 2 diabetes, this depends on the mode of presentation. Like as you said, pruritus valve or pruritus is common. may be presented by loss of anchor reflex, loss of peripheral sensation, hypertension, and signs of atherosclerosis like weak pulsation under dorsal venous artery and periphery over the carotid artery. And a very important point is the presence of signs of insulin resistance. And there are two situations for this. Number one, acanthosis nigricans or polycystic ovary syndrome. What is acanthosis nigricans? Acanthosis nigricans means that there is velvety hyperpigmentation in the back of the neck and intertriginous area. It's very common in the young obese lady. If you see this sign, there are sure signs of insulin resistance, and this patient may develop diabetes at any time. The second point is polycystic ovary syndrome. Also, it is a common condition in young obese lady, in which there is increased excessive secretion of androgens, with its major manifestation like acne or voice, and may lead to anovulation. And this is why most of gynecologists give insulin sensitizer for these patients to help for insulin sensitizer, because they have insulin resistance manifestation. What we should do for laboratory work for hyperglycemia? Number one, if you do urine testing, for example, if you find the glycosuria, which means that glucose urine contain glucose, or positive urine for glucose, it means diabetes? No, it requires urgent blood glucose measurement, and so it is not used a diagnostic tool for diabetes. Why? Because renal threshold for glucose is about 180 milligram per deciliter. However, this shows individual variations. Sometimes renal threshold will be increased, sometimes it will be decreased. There are different causes that may lead to marked decrease in the renal threshold, like pregnancy, for example, or the age, and so on. So this is not a diagnostic tool for diabetes mellitus diagnosis. The second point is blood glucose measurements through the lab using the venous plasma glucose. There are three blood tests that are used for diagnosis. Number one, random plasma glucose level, which means that sample taken at any time of the day unrelated to the last meal. But fasting plasma glucose, no caloric intake for at least 8 hours, but up to 12 hours. And this should be overnight fasting, which is very important point. Water is a caloric, so the patient may say that I can take water. Yes, you can take water, a lot of water, but no juice. Water is a caloric. The third point is 2 hours post oral glucose dose, 75 gram oral glucose plasma glucose. That blood sample taken 2 hours after a person has consumed a 75 gram oral glucose powder dissolved in 250 milliliter water. Interpretation. What are the diagnostic criteria of diabetes mellitus? It depends on the patient. If the patient presented with classic symptoms of hyperglycemia, polyuria, polydipsia, polyphagia, and loss of body weight, any one of the three positive tests, you can consider this patient is diabetic. If what are the cutoff point for random plasma glucose, equal or more than 200 milligram per deciliter. For fasting, equal more than 126 milligram per deciliter. For 2 hours post-prandial plasma glucose, more than equal or more than 200 milligram per deciliter. But in cases of absence of classic symptoms of hyperglycemia, any abnormal test must be confirmed on a subsequent day by any one of the three tests. But two important points here. Patient present with classical symptom of hyperglycemia or prefer random sample. But patient with a classical symptoms, two abnormal tests must be present. But this may be two fasting, yes, okay, but fasting and postprandial is perfect, and also fasting or random sample is perfect. But you don't use two random sample for diagnosis of patient with in case of absence of classical symptoms of hyperglycemia. any level above 100 milligram per deciliter or 2 hours above 140 milligram per deciliter. Since glycosuria is a common manifestation or the common finding in diabetic patient, we should know differential diagnosis of glycosuria. Glycosuria may be associated with high blood glucose like diabetes mellitus, but glycosuria also may occur with normal or low blood glucose. We call it renal glycosuria. The common cause of this is pregnancy, maybe tubular dysfunction, renal dysfunction, or false positive test. Pregnancy, and the commonest cause is due to lower renal threshold for glucose excretion. And this does not indicate or diagnose diabetes mellitus, but oral glucose tolerance test should be performed if the glycosuria before 16 weeks of gestation and the glycosuria on 2 or more occasions later in pregnancy. Also, polyuria is the second common manifestation or symptom of hyperglycemia, but this may be due to pituitary or renal drugs or others. Pituitary, due to impaired production of antidiuretic hormone, which we call it cranial diabetes. Renal, maybe due to inability to respond to antidiuretic hormone. Nephrogenic diabetes insipidus or Fanconi syndrome. Increased cytolytic secretion like diabetes mellitus. A decreased concentrated capacity of the kidney in case of chronic renal failure in end stage, hydronephrosis, hypercalcemia, or hypokalemia. Common use of drugs like diuretics also cause polyuria, other like compulsive water drinking or paroxysmal supraventricular tachycardia after resolution. So there are 3 categories: diabetes mellitus, prediabetes, and gestational diabetes mellitus. Let's start by diabetes mellitus. What is the pathogenesis of diabetes mellitus? Pathogenesis is very important in order to understand what happened for this patient. This, according to the pathogenesis of diabetes, the plan of management should be done. Without knowing the pathogenesis of diabetes, of what happened for any disease, you can prescribe the medications or put a plan for management of diabetic patients. Type 1 diabetes is caused by actual destruction of insulin-producing cells or islet cell or beta cells of Langerhans. So, implication for this is the only medication that can be for this patient is a replacement therapy, insulin therapy. Type 2 diabetes mellitus is caused by a combination of decreased insulin action and inadequate insulin secretion. In this condition, there are a lot of drugs that act through the increased insulin action or insulin sensitizer or insulin secretion that goes to increase insulin secretion and so on. Let's start by pathogenesis of type 1 diabetes mellitus. The pathogenesis of type 1 diabetes mellitus, there are a genetic component which is very strong, also extra genetic factors. And these are the triangle, all of you know that, genetic, environmental, and immunologic defect. And this triangle is present in all autoimmune diseases. All autoimmune diseases share in this, but the difference is only in environmental factors. What's the natural history of type 1 diabetes mellitus? If we see diabetic patient now, we know that this patient passed through 6 stages. The stage number 1, genetic susceptibility. This person or this patient born with genetic susceptibility through one diabetogenic gene within the HLA system. HLA system, you know that occur in short arm of chromosome number 6. Around 90 to 95% are HLA, DR3 and or DR4. In stage number 2, if genetically susceptible individual triggered by one or more of these environmental factors, like congenital rubella, which is the only proved one as time being, but other suggestive viruses include mumps, Coxsackie virus, herpes, and chemical toxins. Exposure of genetically susceptible individual to one or more of these environmental factors lead to what we call immune activation. Once the immune system is activated, it will lead to formation of antibodies against whose own antigen, against the beta cells. and this start the process of inflammatory condition, inflammatory process, or inflammatory encephalitis. And this is the starting point for destruction of the insulin producing cell, and this will be perpetuated later on. This is proved, yes, there are different autoantibodies at diagnosis of this type of diabetes, like islet cell surface antibody or glutamic acid decarboxylase and insulin antibodies. Stage number 4, there is progressive loss of glucose stimulated insulin secretion. Stage number 5 and stage number 6, these are overt diabetes. Overt diabetes, when there is progressive loss of beta cell function of the iris of Langerhans, when more than 90% of the cells are being destroyed, this will lead to frank diabetes. Stage number 6, there is endless beta cell failure, in which there is plasma insulin or C-peptide levels are absent or very, very low. This is summarize the pathogenesis of diabetes, our type 1 diabetes mellitus. The second point is pathogenesis of type 2 diabetes mellitus. In spite of the number of the type 2 diabetic patients much more than type 1 diabetes, but still the pathogenesis is more well established like type 2 diabetes, type 1 diabetes mellitus. But actually we know that not every individual, every person will develop type 2 diabetes mellitus. There are two major main risk factors that make patients susceptible to develop diabetes. Number one, genetic susceptibility. And this is not a monogenic like type 1 diabetes, it is a multigenic. It is likely multigenic. But also environmental factors, second major risk factors like obesity, sedentary lifestyle, physical activity, hypertension, dyslipidemia, increased age, and smoking and stresses. If we see all these environmental factors are endogenous, not like type 1 diabetes, which are exogenous, viral chemicals and toxins, but here all these are individuals. When more than one environmental factor present in the same individual with some genetic susceptibility, diabetes, type 2 diabetes will develop. These factors, two major risk factors, will lead to pathogenic defects. If lead to pancreatic defect or decreased insulin secretion, it will lead to type 2 diabetes mellitus in a minority of cases. But for target tissue defect, which is present in more than 90% of cases, there is a decreased insulin action, or what we call insulin resistance. And the contribution of these defects and which one precedes the other is still controversial. You know that the metabolic action of insulin occurs through the organs, the organ liver. Insulin decrease hepatic glucose production. If there is decreased insulin action, it will lead to increased hepatic glucose production, which is one of the major contributors of fasting hyperglycemia. And there are a lot of drugs that act through this mechanism. Also, in the adipose tissues, they will decrease insulin action, will lead to increased lipolysis and increased circulating free fatty acid, and the muscle decreased glucose uptake. Two deleterious changes occurs. Number one, if the blood glucose start to increase a little bit more than normal, high blood glucose level will further impair beta cell function. This is called glucotoxicity. But high circulating free fatty acids will impair beta cell function and the insulin action, which will lead to lipotoxicity, which is a condition called lipotoxicity. It's a very important slide. If the insulin resistance is the primary defect, the beta cells secrete more insulin to compensate for the peripheral defects of insulin action. And this is a stage of hyperinsulinemia, early stage of hyperinsulinemia. This hyperinsulinemia aims to make patient with a normoglycemia. So, number one, there is increased beta cell function to increase insulin secretion to compensate for the peripheral defect of insulin action. This is a stage of hyperinsulinemia with normoglycemia. But the beta cells will be exhausted later on. This occurs till the beta cell can no longer secrete more insulin, and this stage, the stage number one is insulin resistant, but stage number two, actual decrease of insulin secretion. And this is a stage of hyperglycemia with normal or relative hyperinsulinemia. This is to summarize the pathogenesis of type 2 diabetes mellitus. You know that insulin deficiency, insulin is an anabolic hormone. If there is insulin deficiency, will lead to decreased anabolism. This means that glucose utilization will be decreased, and this will lead to hyperglycemia. On the other hand, once there is insulin deficiency, there is increased insulin counter-regulatory hormones like adrenaline, glucagon, thyroxine, and others. This will lead to increased catabolic process, increased breakdown of glycogen, glycogenolysis, lipid lipolysis, proteinolysis. The precursors of this breakdown of different tissue will lead to formation of glucose from non-carbohydrate sources, a biochemical process known as gluconeogenesis. Again, hyperglycemia, glycosuria, osmotic diuresis, polyuria, polydipsia, and we discussed hyperglycemia and diabetes, but there are three important points all should know. Diabetes is a very common disease, as a matter of fact. 1/3 of cases are undiagnosed, and it's very important, and we know this by screening. There are different studies concerning the screening of diabetes mellitus, and also we usually find that around 1/3 of cases are undiagnosed, even sometimes more. In some countries, this percentage may be increased more, may reach up to 1/2 of cases are undiagnosed. As a matter of fact, from 10 to 20% of cases of type 2 diabetes mellitus have serious vascular disease at first presentation. Again, what are the categories of glucose intolerant? Diabetes type 1, type 2, and gestational. Pre-diabetes also included in the glucose intolerant, impaired fasting, and impaired glucose tolerance. Diabetes mellitus type 1, autoimmune. There are also two types of autoimmune diabetes. Rapidly progressive, which occur in the young. Also, autoimmune type 1 diabetes may occur in the old age, what we call slowly progressive or LADA, or late onset autoimmune diabetes in adulthood. There is a very small minority of cases of type 1 may be idiopathic or non-immune mediated. A very important point you should know: what are the features of rapidly progressive type 1 autoimmune diabetes mellitus? The importance of this, the presence of these clinical markers, you can diagnose type 1 diabetes. Absence of these clinical markers, you can diagnose type 2 diabetes mellitus. A very simple one. What are the clinical markers? Number one, patients are young, less than 30 years, presented usually by classical, acute, and severe presentation. They are never obese. They are ketosis prone. Up to 1/3 of cases presented by diabetic ketoacidosis at onset of the disease. The fifth point, they need insulin for survival. Sometimes, and this clinical marker, you can diagnose type 1 diabetes mellitus or rapidly progressive type 1 autoimmune diabetes in more than 99% of cases. But sometimes, if you are confused a little bit, you can ask for some laboratory markers. The only laboratory markers available, and is perfect to, if you do it, you can diagnose all cases of type 1 diabetes mellitus, is to estimate the plasma insulin and C-peptide. In this condition, in type 1 diabetes mellitus, they are absent or very low. You know that insulin and C-peptide, proinsulin as a storage, يحصل cleavage into inactive component, which is insulin, and inactive component, which is C-peptide, in equimolar amount. And a very differentiating point between type 1 and type 2 diabetes mellitus. Type 2 diabetes mellitus, in 80% of cases are obese, 20% are non-obese, and minor cases present what we call moody or maturity onset diabetes in the young. That's type 1. Type 2 occurs in the young age, like LADA. Type 1 occurs in the old age. Moody type 2 occurs in the young age. This slide shows the comparative clinical features of type 1 and type 2 diabetes mellitus. Type 1 and type 2, age of onset less than 30, more than 30. Duration of symptom and sign, days or weeks, months or years. body weight, they are never obese in type 1. They are 80% or more are obese. Ketonuria and the rapid progression occurs in type 1, not type 2. Family history common in type 2, not type 1. Insulin or C-peptide, as you said, absent or very low in type 1. They are normal or high in type 2 diabetes. HLA and autoantibodies occurs in type 1 diabetes, not in type 2 diabetes, by chronic complications around from 10 to 20% of cases in type 2. No chronic complications at presentation, first presentation in type 1 diabetes. What's prediabetes? Prediabetes is a metabolic condition, metabolic state that intermediate between normal glucose homeostasis and diabetes. It includes individuals who have impaired fasting glucose from 100 to 125 milligram per deciliter, or impaired glucose tolerance from 140 to 199 milligram per deciliter. Previously, it's called borderline or subclinical or early diabetes. What do you mean by prediabetes? Patients with this category are at increased risk for, number one, cardiovascular or cerebrovascular disease or macrovascular complication. I mean, it's the predictor for subsequent development of diabetes mellitus. Diabetic range glucose values are masked with stress. A very common finding that some patients may say that after stressful condition they develop polyuria, polydipsia, polyphagia. Simply before that they are pre-diabetes, and once exposed to some stressful conditions, diabetic range will be unmasked and presented by classic symptoms or a classic symptom of hyperglycemia. What's the natural history of impaired glucose tolerance? If we show this individual later after 10 years, around 33% developed diabetes, other third presented as impaired glucose tolerance, and the other, one third of cases may return to normal. What is not, which is not a feature of type 2 diabetes mellitus? I think all of you can answer this question. Which of the following is incorrect in type 1 diabetes mellitus? I think C, HLA linkage gene located in chromosome number 6. We see that chromosome occurs in short arm of chromosome number 6, not 7. In diabetes mellitus, look for this question, very important question. Type 2 and not type 1 diabetes, which is incorrect. Type 2, not type 1 diabetes mellitus. It is the most common form of the disease. More than 90% of cases have type 2 diabetes mellitus. It's an autoimmune disease in which the immune system is common disorder and is treated by improving insulin. Yes, number B is the correct answer. Glycosuria may be caused by the following except glycosuria. I think all of you know that. Diabetes insipidus not associated with glycosuria. Causes of polyuria include all of the following: diabetes mellitus, diabetes insipidus, polyuria, hypocalcemia or hypokalemia. Yes, we see that, which is include all the following except hypokalemia. No, yes, hypocalcemia is the correct answer because hypercalcemia is associated with polyuria. Yes. Number one, age. She is a female. What's the family history of diabetes? Number three, she does not make any exercise program or comply with low fat or low caloric diet. And also she is mildly hypertensive. She is overweight. I can't use negligence. But there is no symptoms of hyperglycemia. So the fasting blood glucose 140 milligram per deciliter. In spite of the presence of all these major risk factors of diabetes, at this time, you can say that she is diabetic. Yes, you should do another blood glucose measurement in order to see she is diabetic or not diabetic. The third point, or the last point, is the gestational diabetes mellitus. What's gestational diabetes mellitus? Gestational diabetes mellitus means that any degree of glucose intolerance. There is no pre-diabetes or diabetes. There is only glucose intolerance with onset or first recognition during pregnancy. May or may not disappear after delivery and liable to recurrent again with following pregnancy. The magnitude of the problem is around from 2 to 5% of all pregnancies. What's the difference between pregnant women and normal women? Pregnancy is a diabetogenic condition, diabetogenic state. Why? Number one, the human placental lactogen, which has major anti-insulin and lipolytic effect. It increases the blood glucose level and thus makes more glucose available to the face. Number two, steroid hormones have an anti-insulin effect like corticosteroid and the progesterone. Also, they found that some insulin may be destroyed by the placenta. Detection and screening or diagnosis of gestational diabetes mellitus. Pregnant women are classified into high, average, and low risk of GDM. The time and the method of screening depend on the degree of risk. Number one, high risk of gestational diabetes mellitus. What are the factors that make the woman have at a higher risk for development of gestational diabetes mellitus? Number one, if she is markedly obese, strong positive family history of diabetes, previous history of GDM, old age more than 30 years, have history of glycosuria, history of getting large baby later on, before that, history of macrosomic baby. Screening for this category of high risk group, blood glucose testing should be performed as early as possible or as early as feasible during the first trimester using the plasma glucose. Diabetes is diagnosed if the fasting blood glucose equal more than 1, like the same pathway for diagnosis of diabetes mellitus, equal more than 126 milligram or random or post-prandial equal more than 200 milligram per deciliter. Again, the test should be performed on subsequent day unless symptoms of hyperglycemia are present in a classical way. These women who have high risk, not found to have GDM, at the initial screening should be reassessed later on from 24th to 28th week of gestation, the same as women with average risk of GDM. But it's better to do this test monthly because she may develop diabetes mellitus at any time. The second group is the average risk of GDM. Screening should be performed between the 24th to 28th week of gestation. The method by two-step approach. Step number one glucose challenge test from 24th to 24th to 28th week of gestation. No fasting. Give her a 50 gram oral glucose load and the plasma glucose level. After 1 hour, measure the blood glucose level after 1 hour. If it is less than 140 milligram per deciliter, is normal. If it is more than 140, go to the next step. But sometimes we do the second step without doing the first step at all. And if the screening is positive, 3 hours oral glucose tolerance test, and patient come fasting, give and do blood glucose measurement, then give her 100 gram oral glucose load dissolved in 250 milliliter water. Diagnostic criteria for the 100 gram oral glucose tolerance test are as follows. Fasting equal more than 95 milligram per deciliter, 1 hour equal more than 180 milligram per deciliter, 2 hour 155 milligram per deciliter 3 hours. Gestational diabetes mellitus is diagnosed only if 2 or more of these plasma glucose values are found. Even if one of them is odd, high number, but the presence of two is a must for diagnosis of gestational diabetes mellitus. The third category is low risk of gestational diabetes mellitus. No screening is needed for any women fulfilling all the following criteria. But I think if you search for women have all these criteria, it's very difficult. Normal or ideal body weight, negative family history of diabetes mellitus in the first degree relatives, negative history of abnormal glucose tolerance, age less than 25 years, negative history of poor obstetric outcome. Madam Samira is 30 years old, priming. Her plasma glucose 1 hour after 50 gram oral glucose is 130 milligram. What's the normal conclusion? She is normal. Confirmed gestation or needs admission? Yes, she is normal. Result. Second case, a 30-year female has no prior medical problems. As part of a routine obstetric care, she has a blood glucose screen at 24th week. She is given 50 gram glucose to drink, and the glucose level is obtained 1 hour later. Can blood glucose 156 milligram per liter. What you should do? هنا 50 جرام أقل من 140 وأكثر من 140. Do the second step اللي هي 3 hours oral glucose tolerance test using 100 oral glucose loop. The scenario number 1, if the results are yes, fasting 92, 1 hour 179, or 2 hour 172, and third hour is 137. Yes, she is gestational diabetes mellitus or no? No gestational diabetes. Why? Because there is only abnormal figure which is at 2 hours. But second scenario, yes, the results are fasting 1 hour, 2 hour, 3 hours. 2 abnormalities, yes, fasting and 3 hours. So you can diagnose here as gestational diabetes mellitus. Screening for GDM in high-risk women should be done, yes, as early as possible. Which of the following is diagnostic for GDM during 100 gram oral glucose tolerance test? Choose the best answer. I think B is the best answer. Fasting plasma glucose equal more than 95 and 1 hour plasma glucose equal more than 100 milligram.